Good evening, everybody, and good to see you all. It seems you're having a good time, so that's good. And welcome, everybody, for the Innovating the Clinical Blue Book for HCC, the Multidisciplinary Management for Innovative Immunotherapy and Target Platform. I would like to introduce myself, Ghassan Abou-Alfa, from Memorial Sloan Kettering Cancer Center, and with me are Dr. Lipika Goyal, the new section chief for GI oncology at Stanford. Congratulations. And Dr. Ahmed Kaseb from the Anderson, and Dr. Singal from UT Southwestern in Dallas. I would like to thank PeerView and Blue Fairy for providing the session, and for AstraZeneca, Eisai, Exelixis, Merck, Novocure, and providing the educational grants for this symposium. Please complete the pre-event survey. It's very important for us to learn from all of us who are here together on it. So thank you very much for doing the pre-event survey. And at the same time, there will be a lot of follow-up polling during the presentation. So you'll see a slide showing polling, and you'll look at the iPad in front of you, and you'll submit accordingly. And please remember, the iPad stays here, as you heard already. So. And please, we love very much a lot of questions. We are all ready to kind of engage and help in everything we can. So please submit your questions, and we'll answer them during the Q&A session, which is kind of long time for this as well. By the way, the big thanks again for preview, and the slides and the practice aids are now available for you at download, and they'll be after the event immediately, so you'll see that as well. And the agenda is kind of going to be rather loaded, but quick introduction, and then we're going to do 2 seminars on the tumor boards. We're looking to the breaking ground in regard to advanced HCC in regard to the upfront and sequential therapy strategies. And we'll look onto emerging evidence to guide therapy, innovative treatment strategies, and early intermediate HCC. And then we'll kind of, pause for the Q&A as we promised. So very important, what are our goals today, and this is what we're going to achieve together. So we're going to boost the understanding of the latest evidence for modern immunotherapy, targeted therapy, and combination regimens in HCC, enhance the treatment toolbox with skills to create an effective and personalized treatment plan, and equip with the team-based strategies to confidently monitor and manage patients onto modern HCC regimen. And a big thanks is to Blue Fairy, supporter of the program, and this is an excellent resource for professionals, patients, and caregivers. We're really grateful, and Blue Fairy strongly recommend for you, if you are not familiar with them, to really click on that QR code, or at the same time, PeerView and the team has the accessibility to really provide you what will be an incredible resource for your patients in regard to really guidance in regard to the care. And the story of the Adrian Wilson Liver Cancer Association has really been exemplary in regard to what patient advocacy is truly about. So please definitely use the resource. And again, thank you one more time for Blue Fairy for that. So why HCC? As you can see, we don't really have to prove it beyond. If anything, the mortality in the HCC in the United States is increasing. As you can see over here in the orange top dots, we can see that liver intrahepatic biliary cancer or bile ducts cancer are really on the rise. And this is definitely a concerning event that we should really focus on as we continue to have more of the adverse events that really can cause HCC. Besides that, as you can see, the mapping for the treatment of HCC has evolved quite a bit. And if anything, this is a more novel look at the BCLC staging system. Big credit for our dear colleague, Dr. Maria Rieg from the BCLC in Barcelona, that really Dr. Rieg was able to kind of like dissect further, because as we know, the BCLC does very well to the extreme left, as we can see in early stage disease, small, cut it out, small, bad liver, transplant, intermediate stage, maybe look into local therapies. But as you can see, this kind of like triforks that look in the intermediate stage B, this is where we're now looking into either consideration for systemic therapy or combination of, or even reversal of the therapies where we start with systemic, go back to the early stage disease. Please, I would definitely caution everybody and all of us that these are guidelines, they are not really rules, and it's a good idea to put them within the context of what we're dealing with. But really, we are very delighted. This is the wonderful work of many of my colleagues who are here on the podium, as well as many other colleagues worldwide that really led for this kind of, further enhancement of the BCLC criteria or any of the guidelines based on the development of those new therapies. Not only that, but also this is dependent on all the novelty that we all have been involved with. As you can see here, 2000s were really the start of the HCC world, 2007 with the advent of the sorafenib. And then after that, it's not like we're doing nothing for 10 years until 2017, but really a lot of work has been looked into either novelties, approaches, or even combination approaches that sadly did not necessarily fare well, but we learned a lot from it, enough that by 2017 we have the second tyrosine kinase receptor, regorafenib. After that, immediately, for the first time ever, we have the checkpoint inhibitors being looked at with the nivolumab. After all, we continued on those two lines of the tyrosine kinase receptor with lenvatinib in 2018, pembrolizumab in the IO on the other hand. Then in 2019, we have the cabozantinib and ramucirumab immediately after as anti-VEGF. Afterwards, we start moving into the new era with the advent of 2020 with the combination of therapy with the ipi-nivo and then the atezolizumab, and then lately in 2022, the durvalumab. So this is really, relatively speaking, and I'm sure you all agree, compared to any other disease, this is rather very fast in regard to the development of all those therapies, and we're going to cover them all today. And if anything, the algorithm now of the BCLC, this is kind of like a variant of what we just showed a second ago, but as you see, they fit in all those therapies in the guidelines of the BCLC. And again, as I mentioned, these are really guidelines. There are a lot of variations that you can consider in that regard. But most importantly is really what we're going to focus on is that systemic part. But as you can see, it has a lot of arrows that connected to the earliest stage disease and same time could be a two-way street. This is really what's incredible about HCC, is that it's not only a one-way phenomenon in regard to staging of the disease, but you can really reverse from systemic therapy to local or vice versa because of the advent of the disease in different ways with the new therapies that we have as well. And by the way, you have all of this available to you and to download, especially this one is a good tool to at least kind of be able to pull out what will be a good and appropriate approach to the therapy per se. And with this, if anything, yes, there's a big need for all this. So if you're still not convinced why you're having this nice dinner here, so if anything, there is really a lot going on. Based on new data, we can see that, believe it or not, despite all the events that we just spoke about and we're going to discuss in further details, is still a good number of patients can only get only sorafenib. And this is because there's not necessarily a good updates and awareness by all our colleagues in regard to the new therapies that are available to us. And not only that, but many patients go untreated. And especially there's a certain comfort zone in regard to especially the community that, you know what, it's holding, it's steady, not causing symptoms, why should I? And patients maybe might at best get the first-line therapy, but necessarily second line. And what's even more concerning, even for the intermediate stage disease, there's a lot of patients that go without therapy. And these numbers, as you can see, in like on the average, about 50% of patients don't get therapy or some limited therapy is a concern that we are all responsible for and our obligation to continue to be able to get the opportunity for the patients to be treated appropriately and correctly, especially as the median survival continue to evolve in the positive direction for patients. They can really live with HCC. That's the important message that we need to pass on. So with this, I'm going to pass it on to the first seminar. And again, one more time, it's really a great welcome to Dr. Lipika Goyal, who is the Associate Professor of Medicine and the Division of Oncology at the Stanford School of Medicine in Stanford in California, and Dr. Amit Singal, Professor of Medicine and the Willis Mendel Chair at the Liver Disease, Chief Hepatology and Medical Director of the Liver Transplant Program at UT Southwestern in Dallas. Please, Lipika, we'll start with you. Thank you.
Thank you very much, Ghassan. So I'm really excited to talk to you today about frontline treatments and immunotherapy for patients with hepatocellular carcinoma. You know, several years ago, as Ghassan showed with the timeline, we didn't have a lot to talk about. And now the question is, how do you fit everything we want to talk about in a small seminar? And, you know, there's been a lot of tyrosine kinase inhibitors that have been approved in HCC. And now there are multiple immunotherapy agents that are approved in HCC. And that's going to be the focus of my talk today. So we've been, for decades, trying to harness the power of the immune system to fight cancer. And it's really been the last 10 years with the advent of checkpoint inhibitors that we've really been seeing widespread activity in a variety of cancers. And we're very happy that in the last 5 to 6 years, we're seeing activity in HCC in particular. And there are two classes of immunotherapy agents that have been approved in HCC. One is the CTLA-4 pathway inhibitors, and the other is the PD-1 pathway inhibitors. And they have distinct but complementary actions. So the antibodies that hit CTLA-4, they really work on the periphery, on the peripheral cells. They prime T cells, the CD4 positive cells, and those are often in the lymph nodes. And then there's the PD-1 and PD-L1 inhibitors that work on the cells that are inside the tumor and tumor microenvironment, the CD8 positive cells. But those cells have to be present in order for the PD-1 and PD-L1 inhibitors to work. And so we are going to talk about regimens that include one or both of these types of agents. And so where did this story start? The story started with nivolumab, and it was actually the Checkmate 040 study, where the question was, can you safely give nivolumab or give immunotherapy to patients with HCC? And there was concern that maybe there would be liver toxicity, or patients with virally mediated hepatitis, maybe they would have a lot of toxicity. And what we found in that initial study, which was nivolumab in patients with refractory HCC that had previously been treated with sorafenib, we found that patients actually tolerated it very well, and there was a 15 to 20% response rate. And it was based on that study that nivolumab was then moved to the front line in a randomized phase 3 study, in the Checkmate 459 study. And this was a study looking at superiority of nivolumab compared to sorafenib in patients with unresectable or metastatic HCC. And as you can see here, the median survival with nivolumab was 16.4 months compared to 14.7 months with sorafenib. And it did not meet its primary endpoint of showing superior overall survival. So it was a negative study. But it is on the NCCN guidelines for frontline therapy. And there were two main things. One, the response rate with nivolumab was 15% compared to 7% with sorafenib, and the responses were durable. So it showed a certain kind of efficacy that was encouraging. And second, there was a nice safety profile. So this was a survey done for quality of life using the FACT-HEP survey, which is a disease-specific questionnaire looking at the effects of HCC and the treatment of HCC on quality of life. And the completion rate was high, with more than 70% of patients completing at all time points through week 113. And as you can see, the nivolumab arm was favored over sorafenib. So again, this is on the NCCN guidelines. So what were the things that we learned from early experience with immunotherapy? So single-agent nivolumab had durable responses, had manageable safety profile, and promising survival in patients with HCC. And then Checkmate 459 was a negative study and showing superior. And it did not show superiority to sorafenib, but overall still an option for patients. So based on this, we moved over to combination therapy because we found that single-agent immunotherapy was not going to do it. So I'm going to talk about a couple of different combinations. Two are approved in HCC in the first-line setting. The atezolizumab plus bevacizumab combination. Atezolizumab is a PD-L1 inhibitor. Bevacizumab is a monoclonal antibody against VEGF. And this regimen has a couple of claims to fame. First, it was the first regimen to beat sorafenib after many shots on goal over many years. Second, it was the first to have a double-digit response rate, which we had not seen in any randomized phase 3 study in HCC. And third, again, it was the first combination to get approved for HCC. This was for patients who had no prior systemic therapy for HCC. They had a good performance status. They had a Child-Pugh score of A, or category of A, and they all had an EGD within 6 months to check for varices, and I'll talk about that. So this study had a dual primary endpoint for OS and PFS, and you can see for overall survival, it was about 19 months in the atezo-bev arm, about 13 months in the sorafenib arm, and you can see that at 18 months, you can see a separation of the curves that looks very nice. Again, it was also positive in the, for PFS. When you look at the response rate, as I mentioned, a double-digit response rate, 30%. We had not seen this before in HCC. And you can see the duration of response was also very encouraging at 18 months. There's also impressively a complete response rate of 8% in the atezo-bev arm. When you look at the safety, there were no new or surprising safety signals. What we saw was the safety overall favored the atezo-bev arm in terms of less diarrhea, less hand-foot syndrome, less fatigue. You did see some VEGF-related toxicities, such as hypertension and proteinuria. Very importantly, one of the things that we worried about with this regimen was, is there going to be extra bleeding? We know patients with HCC can have varices. Some of them have a history of a GI bleed. And so it was really important as an eligibility criteria for this study that people had to have had an EGD within 6 months, and their varices had to be treated per institutional protocol. And when you look at the rate of grade 3 for bleeding or hemorrhage between the two arms, you see that it was actually quite similar, around 6% in both arms. And so we encourage all oncologists and treating physicians who are taking care of these patients to certainly do these EGDs before people go on to this therapy. So now let's move to a case. So 60-year-old woman with NASH and compensated cirrhosis presented with right upper quadrant pain. Her ultrasound showed that she had a liver mass. The MRI showed that it was 6.5 centimeters, and it had the radiological criteria to show that it was HCC. It had no vascular invasion and no metastatic disease. She had preserved liver function, and her platelets were 90, and her ECOG performance status was 0. She had TACE, and then she was referred for transplant. And then on repeat imaging, she actually had progression, and the dominant lesion was now 8 centimeters, and she had 2 new lesions, 3.2 and 1.9 centimeters. She did have a biopsy of the liver lesion, and that showed that it was HCC. Luckily, her liver function was preserved, and it's always something to think about because sometimes after liver-directed therapy, we do sometimes see a decrement in liver function, but luckily hers was preserved. She maintained her excellent performance status, her AFP went up a little bit, and her EGD showed that she had large varices. So, Ghassan, you are like the best moderator here, so I'll defer to you to moderate the discussion around this.
Sure, absolutely. Thanks so much for this. And if anything, it's very important to really look at the perspective of, number one, the advent of the increase of the cases of HCC, which I mentioned at the beginning, and I'm very glad that the case that actually Lipika is bringing up is actually NASH-based, because this is really the key element over here. With this said, now we have the issue of the recommendation of the referral for the transplant and the TACE. And with this, I would like to really start first always with the hepatologist, because they can give us a little bit of an input in regard to where this might go. And Amit, your thoughts on here. So.
Yeah, so I think, Ghassan, when this patient first presented, they presented within, and we'll get to this, UNOS downstaging criteria, so presented with, even though they're beyond an early stage, they're within, transplant criteria, and I think doing local regional therapy and considering transplant is important because this is a chance at curative therapy up front. Unfortunately, this patient has progressive disease and is would hereby deemed to have TACE failure. And not only because of progression, but even though they remain a Child-Pugh A, you're starting to see the early signs of liver function decrement. And so this is one of the issues with local regional therapy, that you can start to see some decrement in liver function, and overdoing TACE, by the next time, if you repeated TACE, because you're like, oh, they're still liver localized, the next time they wouldn't be Child-Pugh A, they'd be Child-Pugh B.
Sure.
And so at this point, I think many of us, including our center, would move on to systemic therapy, and sort of given the exciting data that Lipika's already presented and will present, we would use an IO-based regimen.
And the reason I start with you, Amit, because it's very important for our colleagues to really recognize that the place where most of the transplant waiting or eligible or potentially eligible patients are actually, most of the time, they spend in the waiting room. And this is really a big problem, is that patients, unfortunately, like our patients over here, really evolve in regard to the progressed disease. As we see now, we have patients now with clearly advanced disease, and same time, however, with varices. And this actually, I'll go back to Dr. Goyal and Lipika, based on the data that you just showed us about like what are the novel therapeutics interventions that you have, what will be, based on those facts that you have in front of you, will be the therapy that you'll recommend now that we clearly need systemic therapy?
Yeah. So given that the patient has large varices, we think of varices either small or large. Given they're large, I would first treat the varices, send to my colleague, Dr. Singal, and ask him to help me out and, see if the patient can get banded or what other treatment he recommends. I think atezo-bev, after people get treated for their varices, is still a safe regimen, but they certainly need to get treated for their varices. But now we also have an additional first-line regimen, so depending on how urgently the patient needs to start treatment, and if we want to start treatment on the sooner side, we have another excellent frontline therapy that we can offer patients.
And how much do you wait between the varices treatment until you consider atezolizumab, bevacizumab?
Yeah, so it's often a conversation with our hepatologists and see how concerned they are and how much banding they did and how long they would like to wait. How do you advise your oncologist, Dr. Singal?
Yeah, so I think that there's the black and white, and then there's the gray zone. So the black and white, so people with a history of variceal bleeding excluded from IMbrave 150, I think we'd all recognize those patients as being high risk of going on atezo-bev. Small varices and no varices, that's the sort of black or white, depending on but you get easy sort of decision in terms of what you would do in that case. And I think these large varices are sort of where you fall in the gray zone. And the management of these is a large unknown. So to kind of come into the IMbrave 150 trial, we know that they were, quote unquote, adequately treated, but the details of that treatment, unfortunately, are unknown. And right now, there's a discord between what some physicians recommend and other physicians recommend. So some physicians would recommend banding, and the typical waiting period after banding would be at least 10 to 14 days, given the risk of banding ulcers and risk of bleeding from BEV, or somewhat related to BEV, and the setting of that banding. Other people in this case, particularly those in Europe, would be much more apt to use beta blockers. You avoid the banding ulcers. You don't have that waiting period. I think this is an area that's a complete gray zone. It's a data-free zone. And the most recent ASLD guidance, which just came out sort of a week ago, says that you can consider one or the other. There's no strict recommendation of beta blockers or banding, but we say at least one session of banding, and we say to wait at least 10 to 14 days before starting BEV.
Fair. And the last question in regard to the case, and Dr. Singal, that's really very important that what you bring up in regard to the banding and the varices, and Dr. Goyal also the choice of the atezo-bev, but also Dr. Goyal, you brought up another option. So let's actually, Dr. Kaseb, ask you, do you really want to go through all of this, or can you consider something else as therapy?
Yeah, so if you ask this question, if you asked it 6-7 months ago, it would have been a dilemma. Right now, we do have frontline immunotherapy strategy that we can use, and so that's one of the patient population that could benefit from this upfront. Also, this case beautifully highlights the importance of the multidisciplinary approach that we all use for HCC patients here. So if we have to use anti-angiogenesis here for any reason, I really think one of the algorithms we follow at our institution is to look at comprehensively at everything. Platelet count, it is 90,000. INR is normal. You look at the portal vein, it's not occupied by a tumor. So you don't have this mechanical, because these issues could, even if the varices are small, could complicate things. If the platelets are 50,000, you have portal vein thrombosis, and the risk, even small varices, they will progress in 6-7 months to large varices. So I agree totally with looking at it from this comprehensive manner, starting beta blockers. A patient like this, I will go for immunotherapy upfront.
Okay. And of course, none of my colleagues brought it up, but I will spell it out. And Dr. Goyal just brought it up already. Durvalumab. Why do we have to go through all of this? Durvalumab is an option. What do you think?
You are heralding my next slide, Dr.
All right, here we go. So let's go. All right, good.
So I think we talked about a lot of these different things, and we want to talk about Child-Pugh B status. If this patient had Child-Pugh B status, what would be the options? And so
Yep.
Right now for Child-Pugh B, we have some data with nivolumab, single agent nivolumab, and that would certainly be an option for patients. There's also data for sorafenib that we can use in the Child-Pugh B setting. We certainly need to develop more data for patients with Child-Pugh B because the vast majority of our studies are in the setting of Child-Pugh A, and all randomized phase 3 studies are in the setting of Child-Pugh A. But,
and we pose a question here for Dr. Singal. In regard to the Child-Pugh B, to be fair, all what Dr. Goyal just brought up is absolutely correct, and this is by the book. But at the same time, there's quite a bit of comfort in regard to the use of checkpoint inhibitors, even with Child-Pugh B. Tell us about that from the hepatology standpoint.
Yeah, I think when you take a look at Child-Pugh B, it's a heterogeneous area, right? So a Child-Pugh B is not a Child-Pugh B. There can be a B7, a B8, and a B9. And there's different ways of getting to be a Child-Pugh B category. I think that we know that a Child-Pugh B7 acts more like a Child-Pugh A, and a Child-Pugh 9 score acts more like a Child-Pugh C. So there's heterogeneity in terms of prognosis and tolerability of these regimens within the Child-Pugh B category. I think we're starting to see some data, not only nivolumab, but even some of these other agents in terms of Child-Pugh B. They appear to be tolerable. I think we're going to need more and more data in terms of what is the actual value of these regimens in Child-Pugh B patients. But I think like Dr. Goyal said, we personally at our center extrapolate the nivolumab data, and durvalumab has become our single agent of choice in Child-Pugh B patients.
Fair enough, good. All right, so we'll move on to what's going to happen afterwards, and you can please carry on, Lipika.
Yeah. So as Ghassan presented this slide, for a while, BCLC staging was really good at helping us think about treatments for earlier stages. And in the advanced stages, we really had sorafenib and not other options. And then as you saw, starting in 2017, we started to have multiple other options. And now immunotherapy and multiple TKIs have made it onto the BCLC staging algorithm and how we treat these patients. So as Dr. Abou-Alfa was bringing up, the regimen with durvalumab and tremelimumab is an excellent option for the frontline treatment of advanced HCC. So this is a combination of durvalumab, which is a PD-L1 inhibitor, and tremelimumab, which is a CTLA-4 antibody. And it was a frontline study in a very similar population to the IMbrave 150 study, with one major exception, which is that this study excluded patients with main portal vein thrombosis. And initially, this study had 4 arms: durvalumab, and low-dose tremi given 4 times, and then durvalumab with high-dose tremi given once as a priming dose, and then the 4th arm with sorafenib. And then based on some phase 2 data, the durvalumab low-dose tremi arm was stopped, and the trial ended up going on as durvalumab, durvatremi, and sorafenib. And there were 2 things that we looked at in this study. One was looking at superiority of durvatremi versus sorafenib, and the second was looking at non-inferiority of durvalumab versus sorafenib. And this was a positive study showing that with the STRIDE regimen, which is again the high-dose tremelimumab for 1 dose, the overall survival was 16 months compared to sorafenib, where it was a little over 13 months. And this was a study which showed that durvatremi is certainly an option for patients in the front line. And also very helpful was when you look at the 36-month overall survival. It was the first study in the HCC where you see a greater than 30% overall survival at 3 years. Sorry, I think I said 3 months, but I meant to say 3 years. And also with durvalumab, it showed that durvalumab was non-inferior to sorafenib. When you look at the objective response rate, you can see that the objective response rate was 20% with the STRIDE regimen, 17% with durvalumab, 5% with sorafenib. And as with the atezo-bev study, we saw some complete responses with durvalumab and tremelimumab. And then also the median time to response was also short at 2 months. When we look at the side effects, overall, it was a study that showed a manageable side effect profile with the combination of tremelimumab and durvalumab. The main side effects we saw were diarrhea, some abdominal pain, some itchiness, some rash. And overall, the risk of having side effects that required steroids, immune-related AEs, it was around 20% with the STRIDE regimen, around 10% with durvalumab. And when we look at other studies with CTLA-4 antibodies in HCC, namely ipilimumab in combination with nivolumab, the rate of immune-related adverse events requiring steroids was around 51%. So overall, this was a well-tolerated regimen with the CTLA-4 PD-1 combination. So beyond durvalumab and beyond durvalumab, there's also another study that showed single-agent PD-1 in the front line. This is another non-inferiority study showing that tislelizumab, compared to sorafenib, tislelizumab was non-inferior to sorafenib. And so now we've had 3 different studies looking at frontline single-agent PD-1 pathway inhibitors compared to sorafenib. Durvalumab showed non-inferiority, tislelizumab showed non-inferiority, nivolumab failed to show superiority, but certainly an option for patients. And so what are the take-homes? How do we think about selection of frontline therapy for HCC? So one of the things we ask ourselves first, as Dr. Kaseb said, he would give that patient immunotherapy. We always try to think, can we give our patients immunotherapy in the front line? If they don't have any contraindications to immunotherapy, then we have 2 great options, atezolizumab and bevacizumab, and durvalumab and tremelimumab. If a patient doesn't have any contraindications to immune checkpoint inhibitors, but they're not an ideal candidate for combination therapy, then as I mentioned, there are a couple different options for single-agent PD-1 or PD-L1 therapies. And then if someone does have contraindications to immunotherapy, then we have tyrosine kinase inhibitors, lenvatinib and sorafenib. The way I think about immune checkpoint inhibitors is you give a patient a chance to hit a home run. You give a patient a chance to really have durable responses. I've had multiple patients who have gone on durva-tremi or atezo-bev, and also even single-agent nivolumab and nivo-ipi, who were on therapy for about 2 years, got off therapy, and for 4 years, 5 years, they have no HCC. And 10 years ago, we could never even dream that with the TKIs, you'd have a patient with advanced HCC who is living for 5 years, and then 2, someone who is off all therapy and doing really well and having one good scan after another. So it's a really encouraging time in HCC to be having all these different therapies.
Well, thank you very much for that, Dr. Goyal, and I totally agree in regard to this. And by the way, please, if you'd like to look into your iPad, and there is some questions that popping up, will be highly appreciated as we kind of gather a little bit more. And you notice, by the way, not to kind of influence the discussion anyway, but as you notice, I kind of express what really is the frustration for all of us, is that really we're so stuck on as if there's only one option. But as you see, there are many options that are available for our patients. And that kind of long discussion that we had, which is totally appropriate and fair regard to the potential for varices. Yes, when there was only a choice of atezolizumab, that's totally understandable. But now, with we just heard about the durva-tremi as well as tislelizumab, and there's more even, I think definitely we have to really think right from the start about all the options that probably are applicable for our patients. But this is really important to carry on with further thoughts, and especially in regard to the emerging data on immunotherapy and combination approaches. So with this, we'll pass it on to Dr. Singal.
I think I have a few more slides.
Yeah. Yes, right. That's right. Yeah.
And so I'll go through these briefly because these are not approved regimens that are options for patients at the moment, but these were trials looking at different combinations. One was the LEAP-002 study, which was the combination of pembrolizumab plus lenvatinib. Pembrolizumab is a PD-1 inhibitor. Pembrolizumab plus lenvatinib compared to lenvatinib alone. And the combination of pembro plus lenvatinib certainly showed encouraging activity. The median overall survival was 20.2 months. The overall response rate was 26 months. And numerically, this was higher than what we saw with the lenvatinib arm. But it didn't meet its primary endpoint, and it was a negative study. But one of the teaching moments from this study was it really echoed the efficacy that we saw with lenvatinib from the REFLECT study. And we saw in the lenvatinib arm that the median overall survival was 19 months. And if we remember from the REFLECT study, the median survival was around 13 months. And this reflects a couple of things. One, perhaps we've gotten better over time in being able to manage the side effects of lenvatinib. It's a learning curve for all of us as oncologists to learn how to give these drugs and manage the toxicities. And then second, when lenvatinib got approved, there were not other options. There weren't a lot of other options in HCC. And now for patients who have progression on lenvatinib, we certainly have other options, so these patients got different treatments. And then the camrelizumab plus rivaroxabanib study. So rivaroxabanib, formerly called apatinib, is a potent inhibitor of VEGFR2, and there was a positive study of rivaroxabanib versus placebo It was a Chinese study. It's called the A-HELP study. It was a phase 3 study in patients with refractory HCC, and that was positive. And then this was moved into the frontline setting in combination with pembrolizumab, a PD-1 inhibitor. And this was a pivotal phase 3 study, and it showed the superiority of pembrolizumab and plus ravisalimab compared to sorafenib. The one thing to know about this study, or a couple things to know about this study, is one, there was a reasonably high rate of grade 3/4 toxicity. It was 80% for the combination compared to around 50% for sorafenib. And as you can see, the hepatotoxicity rate for grade 3/4 was 33% in the combo arm compared to 12% in the sorafenib arm. And then you saw some VEGF-related toxicities such as hypertension and proteinuria, which were also appeared to be higher in the combination. And then this study was also mainly done in Asia. Over 80% of the patients were from Asia, and 75% of patients had hepatitis B. So the applicability of this regimen to other populations still needs to be investigated. This is a study that we're excited to see the results of that have not been reported yet, the Checkmate 90W study. And this is similar population that we've been looking at for frontline studies, the combination of nivolumab and ipilimumab, the CTLA-4 antibody ipilimumab, compared to either sorafenib or lenvatinib, investigator's choice. So going back to Lisa's case, so as Dr. Singal said, this patient was the disease was a taste failure. What if the EGD within 6 months had confirmed recent bleeding or untreatable varices?
So definitely we have more and added on more information over here. So what will be the next plan then? And maybe we'll start with Dr. Kaseb. So what will be next after the STRIDE or the TKIs?
Yeah, so for a patient who had been exposed to immunotherapy and yet the risk of the bleeding is still there, the options are here because you used already dual checkpoint inhibitors, clinical trials versus mass kind of aggressive treatment of the varices. I usually that's one of the reasons I use single agent upfront to save the dual. Durva is approved now, even over nivolumab, because nivolumab has been retracted at a certain point, and now we have Durva versus Durva-Tremi. So for these patients, I usually start with Durva alone. If they progress, I add Tremi. So you still have the option. But if you exhaust both, drugs upfront, you can't even do Nivo-Epi anymore. You have to use other mechanisms of action, clinical trials, or as Amit said, if you have aggressive GI who can get you, the treatment and the banding, and within 4 weeks, you can do that. But apart from that, any anti-angiogenesis would be very risky with recent bleeding.
Thank you for that. And Dr. Goyal, so because you brought up the data in regard to both the Ipi-Nivo and the Durva-Tremi, how much in your experience and in your practice are you seeing the concern about the anti-CTLA-4 adverse events?
Yeah, it's a great question. The thing to remember is they have been approved in different lines of therapy. So Durva-Tremi in the front line, Ipi-Nivo beyond first line after sorafenib. But we do see with the Ipi plus Nivo combination at the doses that were approved by the FDA, we do see a higher rate of immune-related toxicities requiring steroids in my experience and what they saw in the trial, although there's obviously pitfalls of doing cross-trial comparison because one was a frontline treatment-naive setting and one was later lines and slightly different. But overall, I think it's relatively known in the field around tremelimumab versus ipilimumab, the different toxicity profiles. But overall, even with the Ipi-Nivo combination, the side effects are manageable if you work with different experts at your institution, because I think over time with HCC, we become much more comfortable in managing immune-related toxicities. So the key is just to be vigilant for them, get on top of them early, and I find Ipi-Nivo to be also a very well-tolerated regimen for patients.
Thank you so much for that, Dr. Goyal. And Dr. Singal, please, your perspective on that from the hepatologic standpoint and what would you like to add on?
Yeah, I think that one of the differences between STRIDE and Ipi-Nivo is how often the CTLA-4 is given, right? STRIDE is upfront, Tremi one time, whereas the Ipi-Nivo, the Ipi is given over time. And so I think that's probably part of the reason why STRIDE is so well tolerated compared to some of the AEs that we see with Ipi-Nivo. So while the combination is higher than single agent, I think that STRIDE is generally well tolerated, and I think it's part of the reason and beauty of sort of the STRIDE regimen. This patient, Ghassan, to your point, if had the EGD, confirmed recent variceal bleeding or untreatable varices, I think this is generally someone who would not have gone into IMbrave 150, and I think, this patient otherwise is a great candidate for IO. There's no other contraindications. And so if this patient was seen in our center, we would start durvalumab up front.
Yep. No, thank you very much for that. And again, you show our frustration is that really there are options, and already even there are coming from other parts of the world, as we just saw the pembrolizumab, rivaroxaban, the tesmilizumab. So there's a lot of options that we consider for our patients, and we have to really have an open view in that regard. And this is what Dr. Goyal kindly kind of helped us in that regard. With this, again, please, you have some questions that are coming up on your iPad, and if you can help with those as well, will be great. And while we're waiting into this, we'd like to bring one more perspective in all of this. And this is actually an important view that we're excited. We're happy about all the new therapies that are evolving in regard to HCC. But this is nice work that actually was just reported not that long ago. And we can see that sadly, based on what Dr. Monge, who is one of the NCI fellows, has brought in, is that barely the access to clinical trials for HCC in the United States for the Hispanic population, which sadly have high incidence of HCC, is very, very limited. If you look carefully at those thin slivers and all those circles in regard to different therapies, you'll notice that this red kind of sliver is the accrual or add-on of the patients of Hispanic ethnicity onto clinical trials. That's very concerning. And this is really one of the challenges that we have, despite how proud we are of all that work. We want to make sure that's accessible to everybody. And if we were to take it onto a global scale, it's even more concerning. As you should know, that the highest incidence of HCC in the world is actually in the continent of Africa because of the HCC related to hepatitis C in Northern Africa, especially in Egypt. At the same time, hepatitis B with the high incidence of HCC in sub-Saharan Africa. This is work that we just published with aortic in Senegal just 2 years ago. And in polling close to about 400 or so physicians and healthcare workers in Africa in regard to their accessibility therapy, as you can see, sorafenib is still the major driver. And 84% in North and South Africa, where really through the high GDP is still sorafenib. As you see, also in Central Africa, barely 27% have sorafenib. But look at the numbers for atezolizumab, bevacizumab, barely, on the average, about like 4 to 7% of the patients might have access to the atezolizumab plus bevacizumab. What's even more concerning is that, sadly, despite that we proved above and beyond that doxorubicin does not work for HCC, still it's being used in Africa, as we can see over here on the average about 10%. And the last number to be concerned about is that extreme low number in the right lower corner. Half of the 50% of the physicians don't have access to any therapy for HCC in Central Africa because of the cost or because of availability. So as you see, we have to really look into this. I'm not really preaching on that, but it's very important that all of us do recognize how proud we are of all what we're doing. But of course, we have a big challenge, how to make sure that these therapies are actually available and accessible to patients who have the disease, who really need them the most, and not only live with the 10% of the patients who have the disease and the ability to really get access to it. So if anything, how to fix that, because we don't want to just talk about it, like we don't want to say, okay, there is a certain inequity or there is certain issue in regard to accessibility, but how to fix it and how to really look into those diversity inclusion in regard to clinical trials or even accessibility to drugs. And I would love to really, it's an open thought, necessarily in specific question, but I would love to hear from each one of my colleagues any thought that reflect on that data to really see how we can build that perspective. And maybe we can start all the way with Dr. Kaseb, who proudly is from Egypt. He lived and he knows very well about the high incidence of HCC in Egypt. And Ahmed, please, your thoughts.
Yeah, so this is, of course, a global issue that hits home when it comes to hepatocellular carcinoma, because most of the patients, they have this issue even in the US, the healthcare disparity, the high mortality rate in specific ethnicities like Hispanics and African American in the US, for example. And it taps into this big issue of the universal application of drugs and globally. This is not unique to HCC. All other cancer types, even other disease types, right? Hypertension, coronary artery disease, anything preventive strategies and preventive services, such as mammogram and others. So it is a much bigger issue, of course, when it comes to healthcare in general. For HCC in particular, I think one of the areas that we could improve on is to expand access of clinical trials to these underserved populations and countries. In the meantime, before doing that, we have to ensure that there is some infrastructure, the necessary infrastructure to enable us to do those trials, to collect data and samples and test them and so on. So it is much more complicated than it sounds, but we have to start somewhere.
Great, thank you. And Dr. Singal, your thoughts?
Yeah, I think, Ghassan, so thank you for highlighting this. I think it's an important problem. I think there's a couple things. The first is that, we talk about racial ethnic disparities. I think we have to recognize that these disparities extend beyond race ethnicity. There's also studies talking about sex disparities in terms of enrollment and access to these medications. There's clearly socioeconomic disparities which intersect with these racial and ethnic disparities. It's interesting because I actually recently gave a presentation at DDW on disparities, and somebody stood up and asked how we solve that, and I'm like, this is a much bigger question than we're going to solve today. The answer to how we solve disparities is complex and would require hours of discussion, and we probably would still have many more things to talk about. But I think the first thing that I'd say is I commend the pharmaceutical companies, which I think have now, because of these recent data, made a concerted effort to reach out to institutions that actually have increased diversity. So I think you're going to see improvements in this moving forward. But I think Ahmed's point in terms of also establishing infrastructure is important, because we work in a tertiary care center and a safety net health system. The infrastructures for clinical trial recruitment differ between those two different health systems. And I think the first thing that we need to do is not only companies reaching out to these health systems to enroll them, but we have to build infrastructure in these areas that have higher proportions of racial and ethnic minorities, low SES groups. So there's going to have to be a true investment in this from a financial perspective and infrastructure perspective if we want to solve this moving forward.
Thank you for that. And Dr. Goyal, now that you moved to California, and understandably and respectfully, California has a major Hispanic population. Please tell us your hands-on experience, and not necessarily even how you imagine you have a patient of a Hispanic descent, you want to explain a clinical trial. How far would you go?
Yeah, I mean, equally for someone who's not Hispanic, I would say. And I feel like one of the things that we need to do is increase different languages for the consents being translated into different languages, for it being accessible to a lot of different ethnicities and people who speak different languages. I would say one of the great things about COVID is we got to see what it looks like to administer clinical trials remotely. And I think, as Dr. Singal is saying, people live in different areas and not everyone is accessing care at the largest cancer centers, which have a lot of HCC trials. And so one of the things we did during COVID was we would actually administer clinical trials locally where people lived, and they would get their follow-up after they had their first cycle or first couple of months at the mothership where we were giving treatment. We then had people get evaluated by their local oncologist and send in labs and talk to them on the phone, do video visits. And I think if we're able to actually make that work at a larger scale, I think that's going to increase access for people. And the other, may I say one more thing, which is just that I think there's certainly an issue with clinical trial accrual in underrepresented minorities. I think there's an issue with clinical trial accrual generally in adult populations. We know that about 5% of patients with 5% of adults with cancer go on a clinical trial compared to over 90% of patients with pediatric patients. A variety of reasons for that, of course, but certainly I think just a lot more education about what clinical trials can offer and a lot more community engagement around research is going to help the field overall.
Yeah, thanks so much, Dr. Goyal. And you're absolutely right about that. Compared to the pediatric age group, actually in adults, we have really this big general phenomenon. But as you notice, and I like very much what actually Dr. Singal brought in, which is like, how do you fix that? We don't want to continue just to talk about it. If anything, really to be engaged in that. I know humbly, none of us have the answer to that. But at the same time, remember, we're being watched and we're being looked at all the time in that regard. Actually, I just had a meeting with the Attorney General of the country of Ghana, and believe it or not, the question was about how can we get therapy to patients with HCC in Ghana. And that's not only one country, all of them are looking. And as we can see, we have to start thinking, and I know many colleagues from the pharmaceutical industry are sitting among us. This is like the message to your companies. You have to start thinking about this potential market, which really where the need for the therapies are. It's a good, important call that we do for our human colleagues wherever they are in the world with HCC. With this said, we're going to go back to, again, what happened in the second line and what happened at progression and the recommendations for advanced ACC. And I pass it on here to Dr. Singal.
Thanks, Ghassan. So that's going to be a hard act to follow, Lipika. So, it's clearly been an exciting time in the first-line setting, and I think the nice thing is that, the second-line setting has also seen advances. Now the question, much to the sort of same discussion that Ghassan brought up in the first line, is we know there's data, and the question is how do you actually make decisions between all of the choices that you have in front of you in the second line space and latter spaces. So this goes back to the BCLC algorithm, which talks not only about the options that we have in the first line setting, but also talks about options that we have in sequential settings in terms of second line and beyond. So when we take a look at this, I think it's always good to just be grounded in terms of the actual data. So the actual data are these 3 trials, which were large phase 3 randomized control trials comparing 3 different agents compared to placebo at the time. So in order, the resource trial was the first trial that showed efficacy of an agent in the second line setting. This was regorafenib versus placebo. Resource required patients to tolerate sorafenib in the first line setting, but have disease progression, and they were randomized then to receive regorafenib or placebo. And the primary outcome, overall survival, and you can see a significant improvement in survival with a 37% reduction in mortality. Median survival, 10.6 versus 7.8. We then had the Celestial trial, which compared cabozantinib versus placebo. This is, I think the broadest of these latter line trials, because not only did it allow patients who progressed on sorafenib, but also intolerant of sorafenib, and included people in the second line or third line setting, which one would argue now, looking back, was very forward thinking in terms of including second line and third line settings. So about 27% of patients in the Celestial trial received cabozantinib in the third line setting. All patients receiving prior sorafenib at some point. Once again, a significant improvement in overall survival, as well as progression-free survival in the Celestial trial, with a hazard ratio of 0.76 for median survival, point estimates of 10.2 versus 8.0 for median survival. And finally, we have the REACH-2 trial. So the story of ramucirumab is interesting. So ramucirumab first evaluated in the REACH trial, all comers, comparing ramucirumab versus placebo, and in that all-comer trial, ramucirumab failed to show a benefit compared to placebo. In a post-hoc analysis, they started to see a signal where ramucirumab had improved survival versus placebo for those patients with an AFP 400 or greater, and they thereby went back, did a full new randomized control trial, i.e. REACH-2, randomized people with an AFP 400 nanograms per milliliter or greater to ramucirumab or placebo, and once again showing a significant benefit of ramucirumab in that selected patient population. Median survival of 8.5 versus 7.3. Now, ramucirumab is interesting because it's the first biomarker-driven therapy that we have in HCC. That being said, it's important to note that this shows that ramucirumab is beneficial in those patients with a high AFP, not in those with a low AFP, but does not actually demonstrate differential impact versus some of the other therapies. So this doesn't mean that in those patients who have a high AFP, you should preferentially use ramucirumab. It just means it works in that patient population. I think sort of a misunderstanding sometimes of the literature that I see talking to some of our colleagues in the community. So now, all of those trials were with prior sorafenib, and that's because that's when those trials were done. We just heard about all of the exciting advances that we've seen in the first-line setting, atezo-bev and durvalumab now being preferred therapies in the first-line setting. So now the question is, what do we use? We don't have any data that's randomized phase 3 data for therapies after atezo-bev or after durvalumab. And so because we don't have data doesn't mean we have to go back and do these large phase 3 studies, or doesn't mean that we don't have any therapy. We then have to rely on real-world evidence in terms of taking a look at how these available agents work after first-line atezobev or durvalumab. And we're starting to see these real-world evidence studies come to light. So here you can see 2 of those real-world evidence studies, one with lenvatinib and one with cabozantinib. There are many others that are also out there. I could spend sort of hours talking about all the other sort of posters, et cetera, that have been presented. I won't. But I think it's the type of thing where these are meant just to show you that there are data for these TKI agents in the second-line setting. Now, you can see here that lenvatinib had a progression-free survival of around 3.7, cabozantinib progression-free survival of 2.1, median survival estimates you can see there 12.8 and 7.7. This isn't comparative. This is just to show you that these therapies do appear to have some effect and some benefit in the second-line setting, and we can use them. And the studies that exist show a sort of consistent safety profile in the settings after atezobev or durvalumab, as you would imagine earlier settings. Now, we also have some data that's coming out for ipi/nivo. I know ipi/nivo isn't approved everywhere, but as you know, it does have accelerated approval in terms of the US use based on CheckMate 040 data. And we see here that there are some data that are coming out for ipi/nivo in the second-line setting after atezobev failure in the first-line setting. Once again, showing a median progression-free survival of 2.9, median overall survival of 7.4. Not meant to be comparative, but just to know that there are data for these second-line therapies after atezobev or durvalumab. So that's the data that exists. We essentially have randomized data after sorafenib, and we have some sort of case series or small cohort studies after doublet IO and after atezobev and durvalumab, after these doublets in the first-line setting. So let's apply this to our tumor board case. I guess, Kaseb, I'm going to let you lead and moderate here.
Yeah, thanks so much for that. And so this time we have a 60-year-old patient with BCLC-C, Child-Pugh score A, and received as a fourth-line atezolizumab plus bevacizumab, and subsequently progressed on therapy. And within the context of what we just learned from Dr. Singal, we'll probably pose a question first to Dr. Kaseb. So what will be your next step?
Yeah, so this is a real, case scenario here. So we would look at the whole picture here. How did the patient tolerate atezobev? Did they have any immune-related adverse events, or mainly anti-angiogenesis adverse events with proteinuria, hypertension? So that could be a major factor. So it's the patient, condition, also the multidisciplinary look at the patient and his quality of life. If this is a patient who is mainly fatigue and you want to try TKI, you want to avoid TKIs, for example. So here the field is wide open, and the ASCO guidelines and all other major guidelines are allowing us to present patients with all of the front and second line to allow them access to these therapies. So a common scenario here would be to start TKI, and most of us would use lenvatinib, for example. If the patient had a hard time with the anti-angiogenesis, after this regimen, you can do durvalumab. So all depends on how the patient, did, and the big picture. Also the varices here, we didn't talk about it, but a lot of times if this patient has been on the treatment for a year, I always get another EGD. So every year I get EGD because the varices, conditions could change while on therapy.
Thanks so much for that, Dr. Kaseb. And Dr. Goyal, let's assume, just for argument's sake, and see if it doesn't matter, what if the patient was on durvalumab?
Yeah, well, then that patient has not seen anti-angiogenic therapy, and
yeah.
My first choice always for second-line therapy in HCC is a clinical trial, because we have to move the field forward. And so we can certainly use things that are FDA approved and use them for unapproved indications. But ideally, we want to be able to get more FDA approvals, see what actually works, and help patients move forward. So we're happy that so many companies are developing now in the post-first-line space in HCC. But in a patient who had durvalumab and has not had a anti-angiogenic, I think that there are multiple options. I do think lenvatinib is a great choice. I think cabozantinib is a great choice. There's still always sorafenib as an option, and then regorafenib, ramucirumab. All of these are actually reasonable options. But I think one way of thinking about it is doing like T-1 and thinking about first-line options and thinking about lenvatinib and sorafenib. But I think the jury is not out yet about what to use. Could you also use atezo-bev as your next option? It's certainly an effective regimen, and I think a lot of us would also consider using atezo-bev as our next choice after durva-tremi.
Thanks so much. And by the way, thanks for many of you and those colleagues who are online who are sending questions along the same line in regard to can I use checkpointers on more than occasion? And I will hold off on that already. We get some suggestion, at least on the question. We don't have the data, but definitely we'll have a little bit more discussion of that as we go. But back to you, Dr. Singal.
Yeah, so when we take a look at the take-home points for the selection of second-line HCC therapy, basically if somebody receives first-line therapy with these newer agents, atezo-bev, durva-tremi, or single-agent durva, I think that the options for the second-line setting really are TKI or combination IO. Once again, with the data for ipi-nivo coming out after these regimens in the first-line setting. Once again, not randomized data, but these case series that have come out so far. And in those patients who receive TKI therapy, I mean, the nice thing is that this is where we have robust evidence, both phase 3 as well as the phase 2 data, for these different agents, cabozantinib, regorafenib, ramucirumab, combination IO, and once again, the ipi-nivo from CheckMate 040, and the single-agent IO, pembro. So, it really depends on where you start from your first line, but you do have options in the second line, and it's really a matter of, once again, how do you select between these different approaches.
Great. Well, thanks again. And one more time, you have on your iPad some of the questions. Please, if you can help with that. And it will be great if you can answer, especially in regard to those polling, in regard to the second-line therapy, based on what we heard Dr. Singal telling us about, and same discussion from all of us over here. And with this said, we're going to look into the multimodality combinations with regard to advanced HCC. And if anything, we'll continue to carry on.
Yeah, no, thanks, Ghassan. So this is, once again, I think exploratory. This is sort of stuff that isn't readily or often done, but I think interesting data in terms of both emerging as well as hypothesis-generating data, one would argue. So the first is actually the launch trial. So this is lenvatinib and TACE in the setting of advanced HCC, with the idea that potentially treating the liver-localized disease with TACE in combination with systemic therapy would improve survival for those patients with advanced stage disease. So this trial included patients with advanced stage HCC with at least one measurable previously untreated lesion in the liver, so single tumor less than 10 centimeters or multiple tumors with less than 50% of the liver involved. All patients having good liver function, good performance status, and then randomized to these two regimens, lenvatinib plus TACE versus lenvatinib alone, primary endpoint being overall survival. This trial is interesting because, the trial showed a significant benefit of using len plus TACE versus len alone. Median survival 17.8 versus 11.5 months. And you can see the different landmarks of OS at 6 months, 12 months, and then at 24 months all being reported there. This is really a significant benefit in terms of overall survival with a hazard ratio of 0.43. Now, typically, when one sees a randomized control trial that's positive like this would change the field, and this would become standard of care. I think the one thing that to take away as a caveat here is that this trial was largely done in Asia. These patients largely had, hepatitis B. Many of these patients having non-cirrhotic disease. And I think, I've already talked about the decrement in liver function that one can have with chemoembolization. And so I think the big question here is, does this apply to our patients here in the Western world? And I think that remains unknown. And so I think that despite this being a positive randomized control trial, I don't think this has changed practice patterns here in the United States. But it is hypothesis generating. And I think you will see, actually I know you will see because I've sort of seen these trials be proposed, now for patients with advanced stage disease, potentially trials actually evaluating these combination therapies with the new IO regimens of looking at things like chemoembolization, radioembolization with IO regimens for advanced stage HCC. So we'll see if this actually applies to Western world patients in the near future. So the next one, I think this is actually fascinating. So I've had the honor to present this a few different times, and I think it's pretty cool. So TT fields is something that is very different than anything else that we presented. So TT fields are these alternating electric fields that can discharge charged particles during cell division, so during mitosis, and this can lead to cell death. And the thing is that this actually, as you'll see here in this video, it actually is selected to different frequencies, and so will be selected for HCC patients. So it would actually impact dividing cancer cells, but then spare surrounding non-cancerous tissue. So let's take a look at the video and go from there. Oh, no. Are you queuing this up? Okay, maybe we'll come back to the video. Okay, so frequency tuned, so basically will be selective against dividing cancer cells, as I said, and so would impact HEC, and because of this frequency would spare the surrounding liver. And so, once again, because of this, can be very effective, but safe in these patients. Now, when you take a look at this, what data do we have? So this is basically the phase 2 HEPANOVA in advanced stage HCC, relatively small, 27 patients, Child-Pugh 7 to 8. And these patients were evaluated once again in a sorafenib era, TT fields plus sorafenib, and then were followed with CT-MR every 12 weeks. And we can see here in the combination arm here, you can see disease control rate, 76%. You can see objective responses and right around 10%. And so now there's actually a phase 3 trial that's being planned in combination with atezo-bev. So atezo-bev in combination with the TT fields. And this has actually been granted FDA breakthrough device designation in this advanced stage setting. And then finally, we also have data for SBRT followed by sorafenib. This was recently presented by Laura Dawson and colleagues at ASTRO just this past year. And so essentially, we know that SBRT and external beam radiation therapy in general has more and more data coming out that you can actually have very good tumor responses, and given better delivery, you can do so in a safe mechanism and spare surrounding liver and avoid the liver toxicity. And so this was a study that was comparing SBRT followed by sorafenib versus sorafenib alone in those patients with locally advanced HCC, so those patients typically with tumor thrombus. And what we see here is that the median survival for patients in the combination arm was higher than that of the sorafenib arm, 15.9 versus 12.3. The trial failed to show statistical significance in part because the trial was prematurely closed given a change in first-line therapy. So when atezo-bev and durvalumab came to market, the trial actually stopped enrollment given patients, they thought it was unethical to treat patients with sorafenib in the first-line setting. And so they essentially stopped the trial early, but you do start to see a trend with better survival with the combination compared to sorafenib alone. So I think this is now being followed up with proposals to evaluate SBRT in combination with immunotherapy, and so we'll start to see more data for radiation-based therapies in this setting as well.
Well, thanks so much for that, Dr. Singal. And apologies, by the way, I know there was a video, but we have to still give credit for this incredible novel approach for therapy, as we just heard it from Dr. Singal. And I hope we'll have the opportunity to see more of this therapies that will depend on the electromagnetic waving that will actually alter the division of the cells and lead to therapy. We know that this is already approved for glioblastoma, and definitely we look forward to see more activity in regard to HCC as well. With this said, however, there's more emerging evidence of guiding therapy, and for this, we're going to look into the innovation treatment strategies in early intermediate stage. And for this, Dr. Kaseb, the floor is yours.
Thank you, Hassan. So my job is to make a case for systemic therapy in early stage disease. So as an oncologic standard rule, whenever we have local tumor, we do local therapy. And that's because it's more effective, it's more tolerable, and avoiding the toxicity of systemic. So why are we trying to shake the ground here and make a case for systemic therapy in localized HCC? Two major pathognomonic features. I'm going to pause here for like 20 seconds just to explain that, because it's going to help us understand what we're trying to do here. And for those of us who are young and the trainees, if you understand these pathognomonic features, you're going to understand every single aspect of HCC, from screening, diagnosis, all the way to selection of therapy and prognosis. So one is, this is an angiogenesis-driven tumor, so we rely on that even on imaging to diagnose HCC without a biopsy. You see the hypervascularity washout. And then this is a tumor that is very rich in immune cell infiltration. And that's because the liver is an immune-tolerant organ. We have the portal circulation, pathogens and nutrients coming from the portal circulation, and that's why you do have the immune cells turned off. So that's why these two features, pathognomonic features, are going to really help us understand every single aspect. It's a recurring theme. The first one here is the immunomicroenvironment, and you look here on the left-hand side, you will see very unique number here, which is 30% immune class. So this patient population have active immune cell infiltration. And if you have noticed by now, all of these slides, this is the glass ceiling of any dual checkpoint inhibitors, of any double agents in HCC. We hit the glass ceiling with single agent, TKI around 10%, immunotherapy, single agent 15 to 17%. When you use combination of anything, you go up to 25, 30%. So that's the immune class. On the right-hand side, the immune intermediate and excluded. This is where we have the major issues with patients progressing through therapy, resistance to certain therapies as well. And then I mentioned that the recurring theme is going to be between angiogenesis and immune environment. So this is the case here for anti-angiogenesis therapy with the VEGF angiogenesis-driven tumor. So you will see here the interaction and the synergy, the potential synergistic pathways combining anti-angiogenesis and immunotherapy here. And just to list very few, we're not going to go through all of them, the effect on the trafficking of T-cell infiltration, the activation and the priming, cancer antigen presentation. So there is very strong rationale to use both. Those pathognomonic features really led us to believe that patients are going to benefit from these two agents together. And then, this is also a very important concept in HCC, and that explains why patients on the lenvatinib TACE, for example, or SBRT, sorafenib, had better survival advantage. And that's because our patients die from liver failure because of the local tumor progression. They don't die from lung lesions or lymph nodes or even bony metastasis. So that's why the pattern of the patient's progression and the survival advantage of combining systemic therapy with localized therapy is very justified here to maximize the tumor control and offer them survival advantage. So this is the list of the rationale here. Intermediate stage is very heterogeneous. You have tumors going from nodularity and size and distribution, underlying liver function. So there is always room, even in localized disease, to jump to systemic therapy, even if you're not doing local. The efficacy of the local therapy is also affected by the tumor burden. We learned that from the TACE. The initial studies, average size was 5 centimeters, and then people were using it left and right, 10 and 15 centimeters. So they have, in these cases, to do multiple therapies, and liver function goes down. So, and then we look into missing opportunities here for systemic therapy if the liver still preserves the function. And we do have level 1 evidence for systemic therapy. Believe it or not, none of the localized therapies have that, even TACE itself. So level 1 evidence with systemic therapy, the increased response rate in systemic therapy combinations led us to believe that there is room, even in early stage disease, to advance systemic therapy approaches. And then, of course, finally, potential advantages of incorporating the systemic therapy in early stage disease because you have this effective therapy, starting it earlier while the liver functions are maintained, more effective intervention before the liver decompensation after localized therapies, and then potentially increasing the cure rate. Why that? Because you could offer those patients curative options after downsizing, for example. So for those who were borderline resectable or transplantable, this approach could make them amenable for curative options. This is a busy slide, but the take-home message here is, there is a rationale to look into multiple factors to assess and predict response to localized therapies. For example, here for TACE, this prognostic score was developed, and it's based on the liver function, the presence or absence of metastasis, history of tumor rupture, for example, also GI bleeding or ascites, the decompensation of the liver, and then patients get the score, and if it is less than 6, meaning that they really check all boxes and they're in excellent shape, liver functions are maintained, then those patients have the highest survival of 49 months, and then of course it goes down with patients with very advanced liver disease and tumor parameters as well. And this is kind of more of the same here to show us that intermediate stage is a very diverse group. So it's called intermediate because there is no metastasis or vascular invasion, but that's a very wide spectrum. It goes from single tumor to innumerable tumors, from single lobe to bilobar disease. So of course, needless to say, the smaller tumors localized to one lobe are going to do much better than advanced tumors in both lobes of the liver. And this approach has been, pushed further to change the status quo here and look into the fixed beliefs in our mind that patients with localized disease would only need localized disease has been challenged recently. So, for example, here, lenvatinib versus TACE study looked into just that and showed superiority of lenvatinib over TACE. Along the same line, ongoing phase 3 studies are challenging this concept, and you're going to see more effective systemic therapies randomized to localized therapies. These are the historic studies with the TKIs here, and of course with the TKIs, the effect of the TKIs themselves was very modest, so that's one of the reasons. Also the fact that most of these studies, they use different kind of strategies. So a lot of them actually did what we call adjuvant systemic, meaning you do the TACE and then you randomize patients to adjuvant sorafenib versus placebo, for example, rather than starting both of them together or randomizing to the local therapy rather than systemic. So all of these things led to a lot of failures in systemic therapy trials until we started to see more effective systemic, until we started to see more smart way of randomizing those patients rather than the old kind of adjuvant strategy. Of course, the next wave with the emergence of immunotherapy and the efficacy of immunotherapy in HCC is going to really be going that direction, combining local and systemic here meaning immunotherapy regimen-based regimen, either alone or combined. And of course, the episcopal effect here, meaning that the localized therapy will induce this systemic response that will mobilize the immune cells from lymph nodes to the microenvironment. So you're expected, even if you do TACE in the liver, to see this systemic response, and you could see even responses in the metastatic lesions based on this rationale. And this is an example here of a study that did just that with ablation, local ablation, and showed the effect on the microenvironment and circulating levels of immune cells. And this is just a short list of what's going on nowadays. So you do have, in terms of local therapy approaches, TACE versus Y90, DIP-TACE, and you have different regimens, systemic therapy, either immunotherapy alone or in combinations. And this is another study that also is a global study, TACE in combination with Durva and bevacizumab in patients with local regional therapy, and that's compared to TACE Durva alone or TACE alone. And this is another study that also looking into different regimen, Durva-Tremi, lenvatinib, plus TACE versus Durva-Tremi, TACE versus TACE. And that's atezo-bev with TACE, and this strategy here is to assess whether you can do atezo-bev before TACE or you can do it in combination. So you'll see all of these studies trying to answer very, very specific question here, which is immunotherapy alone sufficient in this population? Is immunotherapy in combination with the local therapy better than local therapy alone?
Thank you very much for that, Dr. Kaseb. And it's incredible to see all those kind of innovative approaches, and now that we have all those mixed or mixing those assets that we have at hand. Please, one more time, we have to ask you please to look at your iPad and answer the question regarding the intermediate stage HCC before we move on. Thanks for that as well. And if anything, we'll carry on in regard to, again, combination immunotherapy with surgery as well. And Dr. Kaseb, please.
So we just talked about the local therapy approaches and how we are looking at it nowadays with the development of the more effective systemic therapies. How about pushing the envelope even more and more in terms of patients who undergo surgical resection? So this is a very unique patient population. They come, they have resectable disease, good liver functions, and then they go for surgery. However, the recurrence rate is very high, and that's the dilemma here. And there is no approved neoadjuvant or adjuvant therapies. So the next few minutes will be focusing on this population here. So this is this population. This is how we look at it in clinic, right? So you do have to have very specific guidelines to enable resection in HCC, and that's because most of the patients have underlying liver disease. So they have to have enough liver remnant. So for example, here for the future liver remnant has to be more than 40% in cirrhotics. So this is very important. Also, as another major rule here, we never resect by lobar disease. So unlike colorectal metastasis, for example, with the segmentectomy, so it has to be one lobe. You have to have enough liver remnant. And then, of course, you know, the effect of the underlying disease leading to portal hypertension is another dimension here. So you see how complicated it is. We look at all of these features. We get EGD done. We look at the imaging characteristics, if there is any advanced cirrhosis, large spleen, platelet count, all of these things factor in terms of selection of potential surgical candidates. However, 5-year overall survival here is in terms of patients with resectable disease is only 70%, and that's because the majority of patients get recurrent disease, over 70% in 5 years. And this is, you know, illustrating just that here. Depending on the number and the size of the nodule, there is a very specific correlation. And if you go to pathology literature, this is very consistent. Single tumor, less than 5 centimeters, they do best no matter what we do to them. TACE, surgery, radiation, even systemic therapy. And if you go with this, along this line with the surgical patients, they have the lowest recurrence rate. And that's because the tumors are more well-differentiated. They don't have a lot of microvascular invasion, for example. So larger the size, the more the number of tumor nodules, the worse the outcome and the prognosis of HCC. And that's why, you know, moving up, you know, we talked about systemic therapy with local therapy in terms of intermediate stage. This is early stage disease here. How about moving up systemic therapy to the patients who are amenable for surgical resection? Very strong rationale, of course. For example, here, looking into the anti-angiogenesis. Of course, you know, in terms of angiogenic switch, you know, in terms of the growth factor that can lead to recurrence and poor prognosis after surgery. IMBRIV 050 tested this concept based on the recent approval of atezobev and the validation of this concept in HCC in general, and the validation of targeting both pathways, anti-angiogenesis and the immune microenvironment. So this study looked into patients who will undergo resection or ablation, and then stratified based on the common features we talked about in terms of the tumor size and number, the necessitated for those patients to be enrolled if they have high-risk features, and the risk features are listed here, and just like what we discussed earlier, based on the number and size of the tumors, and then was randomized to atezobev in one arm versus just active surveillance in another arm. And then you will see here one word about allowing one cycle of TACE. That's because in Asia, they do this, TACE to the surgical bed after resection. And the patient characteristics here were equal, and the take-home messages here is that most of the patients from Asia, 82%, most of the patients had hepatitis B, 62%, and patients had mainly ECOG status of 0, some 1. And then in terms of the tumor characteristics here, 90% of patients had single tumor. So when this study was launched, the hope was we're going to get a good number of patients with real high-risk features. However, because there is a mix of features here in terms of vascular invasion, for example, so you could have one single tumor, but they have poorly differentiated pathology, or one single tumor, but they have vascular invasion under the microscopic vascular invasion. So this study ended up with mainly one tumor, uninodular disease, as we see here, and then the rest of them were equal on both arms. And then you see the results here. The study reached its primary endpoint, which was the significant decrease in recurrence-free survival here. The hazard ratio is 0.72, so there was 28% reduction in risk of recurrence here. However, as you will notice here, that the effect was major in the first year, and you start seeing the effect weaning off later on. This is a busy slide, but again, the take-home message here is that based on the fact that some patients had higher risk than expected, you see that some patients, even on the randomized arm to just surveillance, did better than expected. And we see here that the effect was less prominent in the second year here. So is it just because we are delaying the recurrence rather than preventing it? Or there is, the ERASL here. This is a score looking into patients who undergo resection, and they stratify them into different risk groups. And the risk group here matched with the intermediate because patients didn't really have high risk features. And in terms of the subgroup analysis here, as expected in those large randomized studies, most of the time you see the effect of the overall study panning out in subgroups as well. And along the same line, we have other studies ongoing with adjuvant Durva here in high-risk group, Durva plus Bev versus placebo. Ongoing adjuvant trials here, the same concept looking into immunotherapy versus placebo. And this is a patient here who was found to have extensive microvascular invasion at resection, 50-year-old with hep C, sustained viral response, and had large unifocal disease, 7.5 centimeter, no imaging invasion, vascular invasion and imaging or distal metastasis, excellent liver condition, underwent resection. What would you do for this patient?
Yeah, thanks so much for the Kaseb. And let's start with Dr. Goyal. So what do you think about this situation?
Yeah, well, given this patient had resection of a large tumor with high-risk features, so greater than 5 centimeters, and had microvascular invasion, and had poor differentiation, so multiple high-risk features, certainly this patient is at high risk for recurrence. I think it's certainly worth a conversation to talk about consideration of adjuvant atezolizumab plus bevacizumab. Right now we saw the early data with the interim analysis, and I think we need to see longer-term follow-up. But given the positive trial from what we see so far, certainly worth having that conversation with the patient.
Absolutely. Thanks so much for that, Dr. Goyal. And Dr. Singal, understandably, the two drugs are available. Are you ready to apply it, or would you wait for the final publication? And please tell us, what's your thinking process when you have novel therapy like the AMBRAVE 050?
Yeah, so I think we were at our center, we were waiting for the actual presentation, so we obviously didn't do it on the press release. We wanted to see the actual data, but now that we've seen the data presented, we feel like we have enough of an understanding of the data where we are now talking to our patients about adjuvant therapy at this time. We're not waiting for the full publication. That being said, one of our team members is on the steering committee, so we actually we know the trial well.
Fair enough, fair enough. Thank you for that. Okay, so this is understandably now another situation, and we have a 60-year-old gentleman with NASH and multifocal HCC, 4 lesions, largest 5.2 centimeter, with no vascular invasion, no metastases, 3 lesions in the right lobe, 1 lesion in the left lobe, Child-Pugh score A and appropriate numbers, but platelet count 97,000. And the question is, transplant, yes or no? And go back to you, Dr. Kaseb.
So if you follow transplant, even the extended criteria with 4 lesions, so this patient would not be amenable for transplant. Downstage, yes, this is one option, especially for 62-year-old patient. So at our center, we would go aggressively here in terms of treatment options. For a patient like this, with this borderline liver function, I would start with systemic therapy based on the data showing that there is an advantage there in terms of even early stage disease patients. So I would start systemic here, hoping that we can downstage. I would definitely use immunotherapy combination.
Sure, thank you for that. And Dr. Goyal, please give us your perspective. What's downstaging?
Yeah, so there are different opportunities to downstage patients. We know in this country that it takes 12 to 24 months to get a transplant, depending on your blood type and a variety of other factors. And so because there's a waiting list for a liver transplant, we have to keep patients within criteria in order to be able to get them transplanted. There are some patients that are within Milan criteria and they can get transplanted earlier, but some patients are beyond Milan criteria, but still within UCSF criteria. And we can do a variety of different maneuvers to try to decrease their tumor burden to get them to within Milan criteria. That's called downstaging. So we can use systemic therapies. One option, as Dr. Kaseb mentioned, we also have liver-directed therapies such as Y90, TACE, radiation, as options to decrease the amount of tumor burden to get people within Milan criteria.
Thanks for that, Dr. Goyal, and you gave different perspective on that. Biologically, Dr. Singal, are we justified to downstage?
Yes. So, we know there's actually a large randomized control trial for patients who are beyond Milan who were treated with local regional therapy, had a response, and they were randomized at that point to continue their current course of therapy or to undergo transplant, and significant benefit of liver transplantation. So we know that this is actually beneficial to those patients and should be considered standard of care. It's built into the UNOS policy, so these patients get exception, just like presenting within Milan. So this is standard, I would argue, standard of care. To Ahmed's point, this patient presents with it beyond UNOS downstaging. So they have 4 lesions, largest 5 centimeters. So they're beyond UNOS downstaging, although it doesn't mean we can't downstage this patient. And so if this patient was seen at our center, we would still talk about downstaging, and we would talk about doing so via a living donor pathway. And so this, at least the data suggests that the survival after liver transplant in those patients beyond UNOS downstaging is not the same. It's slightly lower than those patients within Milan or within UNOS downstaging, but still very excellent. You still achieve 5-year survival of 50, 60%. And that isn't achieved with local, regional, or systemic therapy. And so in a young patient like this, and I guess I'm not anywhere close to 62, but as I get closer every year, I start to change what my definition of young. In this young patient, I think it's something that we need to consider. And I think it's the type of thing where tumor biology, because of waiting times, will declare itself. If this patient progresses, systemic therapy is fine. But this patient may have actually had 4 lesions. You treat them, no new lesions pop up. This patient would benefit from transplant.
Thank you for that. This is a very important point. That's why we asked the question to justify that biologically, which is great. And please, one more time for all our colleagues, so on the iPad or if you are virtual, please, if you can answer the question that we brought up in regard to the management post-resection, would really appreciate that. And thank you. And we carry on. And if anything, we'll back to you, Dr. Kaseb.
Yes, so now we're going to even, look into some more intriguing, ideas here. How about patients who are going for surgery, delaying their surgery to allow us to do immunotherapy? Would that be justified? Would that be even helpful? So there is a very strong rationale here, of course, right? We talked about validation of immunotherapy in HCC, in metastatic disease. We talked about the adjuvant strategy here. How about, new adjuvant therapy with immunotherapy before surgery, and would the adjuvant strategy here, approval of atezolizumab, affect future trials in this space? And then we talked a little bit about benefit-risk assessment here after resection for the adjuvant, but we know for reality is once this is approved by FDA, everybody's going to use it. So what's going to happen to the new adjuvant space here and the future of these trials?
Thank you for that.
So this is a study we did at our institution here looking into Nivo versus Nivo-Epi in patients with resectable disease. This was the first patient on this study here. You will notice that this patient had a hypervascular tumor turned into very dark tumor, so that's by imaging, complete response. And then this was validated based on the pathology. So this was the first case ever in HCC to show this complete pathologic response after neoadjuvant therapy. And this was only 6 weeks of therapy. The study was completed. 6 out of 20 patients achieved this kind of response. 5 of them, 100% necrosis, and 1 of them had more than 50%, so major pathologic response. None of the 6 patients recurred, and the other 14 patients, half of them recurred. So you do have this over 3 years follow-up after this study was completed. Another study looked into similar approach with neoadjuvant Cabo plus Nivo, and that was done at Hopkins here. Showed similar pilot prelim results here in terms of a major pathologic response. 4 patients out of the 15 achieved more than 90%. And this is a study ongoing at our institution with neoadjuvant atezo-bev based on the recent data. So this is 3 cycles followed by washout and then surgery. And then I'm going to turn it to Dr. Singal to talk to us here the last few slides about transplantation for HCC.
Yeah, I know we're at time, so I'm going to try to hold myself back. I like to talk, so I'm going to try to hold myself back. And I don't know if you're sort of sitting here as your dedication or the fact that we're such good presenters. So, but maybe a combination. So, okay, let's go through this quickly. We've already heard transplant is a great therapy, right? It's a curative therapy for both the HCC as well as the underlying liver disease. So one can argue it's really the treatment of choice for anyone with underlying liver dysfunction. Of course, there's limits in terms of what we can do this, and we've already talked about downstaging. So even beyond Milan, you can achieve very good outcomes for those patients with larger tumor burden that have a response to therapy, come to within Milan, and these patients can achieve very good survival. Now, why are we talking about this? This is a talk on systemic therapies, and I think the interesting idea here is that we used to think of bridging and downstaging exclusively with localized therapy, TACE, TARE, et cetera, and there used to be fear of using immunotherapy in this setting, right? I mean, you're essentially taking something that is increasing your immune system, and then you're transplanting them and putting them on medications that inherently suppress their immune system. And when those patients have immune activation, they're at high risk of rejection. And so there used to be fear of this because of some case reports of using IO agents after transplant, resulting in almost near universal bad outcomes, rejection, death, et cetera. However, recent data suggests the safety of immunotherapy prior to liver transplantation. Very exciting data that comes out of Mount Sinai, relatively small data set, but these patients received nivo while on the transplant list, including one patient who received nivolumab the day prior to liver transplantation. I am fascinated by that one patient. But received nivolumab prior to liver transplantation, and these patients actually did well post-liver transplant. So not having rejection, having very good outcomes, and so this at least makes us reassured that this may be a viable strategy. Now, there are studies that are actually going to prospectively evaluate this. So this is one study looking at durvalumab and those patients who are listed for liver transplantation. And it's really the primary endpoint here is taking a look at the proportion of patients who have rejection after. So this is how much of a change in the field there's been in terms of not only using this sort of, in aggressive centers, but now actually industry coming into this space and doing trials. This is, there are other trials also looking at neoadjuvant immunotherapy prior to liver transplantation. Once again, you can see them listed here, and I think that we will have more data showing, hopefully, safety in those patients prior to transplant. I think the one thing that I would say is that there are data prior to transplant. I think we should not be using this after transplant. I think that's still one area where there's high risk of rejection and high risk of adverse events. Ghassan, I'm going to turn it back to you.
Yeah, thanks so much for that, Dr. Singal. And please, the last point that Amit wrote in is very critical. Pre-transplant, yes, we have data, we have studies coming on, but post-transplant, please, this is not to be used for that purpose. And if anything here, we leave you with some key home messages, and we're going to take a few minutes. I know we're a little bit behind time, but it's critical. I really feel obligated to answer you some of the questions. But number one is continued advances in regard to the combination therapies, as we heard first from Dr. Goyal, in regard to the anti-PD-1, anti-PD-L1 scaffolding of the therapy. Definitely we look forward to better global access to advanced therapy for HCC. And by the way, thank you very much for all those who asked questions in regard to this accessibility, either clinical trials or therapy that are already approved. There is a thorough analysis in the context of the study-specific demographics that really is needed, and especially some component we didn't talk about in regard to etiology and other factors that could impact the immune microenvironment. Sequential therapy is an evolving field, and remember, we really put it in based on what the data has shown. And some of the questions were brought in regard to, is there any justification for doing combination therapy versus sequential therapy? And this is something definitely that needs to be looked into further as well. The combined therapy evaluation is still underway, and we heard quite a bit of that in regard to the second-line effort from Dr. Singal. And of course, the integration of the systemic therapy into the early-stage disease continue to evolve, and and there's ongoing trial, as we heard also from Dr. Kaseb. With this said, I will only take the 3 key questions, and it has been really flooding over here with questions, but the only question that we brought in, and I'm going to do it rapid fire style, so in other words, yes, no, and I will ask Dr. Singal the first question, biopsy, yes, no.
It's a more complicated answer than yes, no. If you're going to
You can give me the yes or the no, and then we'll evolve on the but.
more yes than
Yeah,
it was before.
Perfect. Okay, more yes than no. And this is understandably for 3 couple components. Number 1, the biology diagnosis is critical. There is a potential for a combined or even potentially other diagnoses or required to do that. Number 2, we needed to evolve on all what we heard from all of us regarding to biology. If we don't have the tissue, we'll never be able to understand what we're doing. And as you see, most of the studies are actually have the tissue as a requirement. And the second rapid fire question that is for Dr. Goyal. So, immunotherapy as second line. You brought it up again one more time, but it's coming back as well. Are you ready to give checkpoint inhibitor therapy after you used it as first line, yes or no?
Yes.
And if anything, the scaffolding that we're talking about, I totally concur with Dr. Goyal that maybe the studies are not there yet, but understandably kind of like bringing in more potential for the immune cycle of the cancer cells will probably be valuable. And this is what we encourage actually to see those studies ongoing per se. And the last question, again, a yes or no for Dr. Kaseb, which was really brought up one more time. The adjuvant therapy, tomorrow morning, you know, we're Friday, Monday morning, you're going to give the atezolizumab yes or no as adjuvant?
I would wait for the FDA approval. I usually don't do it unless we really have because the regulatory body of the FDA is designed that way to look at the data. And so I would definitely wait.
Sure. So this was, by the way, a long no. So if and if anything, understand it. We do respect that. I think Dr. Singal also brought it up. We're always thoughtful and careful in regard to when do we apply therapy. We're definitely happy to see that. It's an exciting thing, but we just have to wait for the details of it. So with this, we thank you very much for staying with us that long, and I hope this was helpful. And for our colleagues who are really following us also virtually, thank you for being with us, and I wish you a great evening and good luck and enjoy your ASCO. Thank you.